Welcome, everybody. Nice to have you here. Good morning from Philadelphia. We are once again happy and proud to welcome you to what is our 10th edition of the case competition. This time focusing on the African continent and with a little bit of a different agenda for today. Before we start, as usual, we would like to thank the entire team. Remember that this is a collaboration between the Perelman School of Medicine Center for Global Health, the Department of Radiology of Penn Medicine, and the Children's Hospital of Philadelphia. We count with the support from all of our departments and thank our sponsors in each of the departments. The entire team is here at one of the research buildings in Philly and ready to get us started. Again, thank you to all the trainees that submitted cases. That's always fun to review the cases and see the amazing things that are happening in other places. Thanks for all the work that it involved submitting your cases and submitting your videos. We also want to thank all our team that supported the submission and the judging of the cases and the invitations and all the logistics. And with that in mind, Farouk is going to go ahead and introduce our, I guess at this we're going to say it twice, both at the beginning and at the end. A reminder that the winners for this case competition, or that this 10th edition of our case competition counts also with a special sponsor from our SNA. And the two winners will be, RSNA agreed to sponsor them to attend RSNA in 2026. Again, not this November, but next November, we'll see the winners in Chicago. So again, a lot on the line today. Keep raising the stakes here. Farouk, why don't you introduce our panel and move us along? Thank you, guys.
Well, thank you, Hansel, for getting us started. As was mentioned, it's always exciting to do this again. So without much ado, I'm going to move on to the next part of this program, where we have assembled a panel to have a great conversation about non-communicable diseases in Africa. And so I'm going to go ahead and introduce our panelists who are going to share a lot of knowledge with us today and hopefully have a great conversation. So first is Dr. Princess Achempong, a public health lecturer and researcher at Kwame Nkrumah University of Science and Technology in Ghana with expertise in health interventions, nutrition, and implementation science, dedicated to improving community health and mentoring young women from disadvantaged backgrounds. Next, we have Dr. Jacqueline Wogwi, who is a researcher at Muhimbili in Tanzania, also expertise in implementation science, health economics, with a focus on tuberculosis, HIV, and non-communicable diseases. Next, we have Dr. Davis Amani, who is an EPI at MUHAS as well, with a focus on research and dissemination, stakeholder engagement, and enhancing health policies in Tanzania. Also works on improving surveillance systems for road traffic injuries and cancers, while coordinating capacity building initiatives in scientific writing and research management. And last, but certainly not the least, our own Yehuda Marte here at Penn. She's a physician in Hemonk with a research focus on improving access to cancer treatments and outcomes for breast cancer patients in sub-Saharan Africa. She has contributed to global efforts, including serving on the WHO Steering Committee and updating the model list of essential medicines for cancer and assessing the impact of essential medicines, access, and cancer outcomes in lower middle income countries. She's from Ghana, but most importantly, she is married to a Nigerian. And so with that being said, I'm going to start off our questioning with a question for all panel members, which is, Could you please share your general thoughts on the shift in health burden from communicable to non-communicable diseases, and what advice you have for African countries to adapt their healthcare systems to face this new challenge? And so this question is addressed to every member of the panel.
Thanks so much, Farouk, for the introduction.
Yehuda, please,
it's a pleasure
go ahead
to meet.
and kick us off.
Oh,
You're on mute.
I'm on mute? No, I'm not.
I'm on mute.
Am I transmitting okay? Okay. So yeah, thanks so much. Feel very honored to be part of this panel and this competition. So I think a lot of the work that I do is in Botswana, and also I am from Ghana, so I've done some work previously. I think in terms of global trends, the WHO just released new statistics. And so I think objectively speaking, we do know that non-communicable diseases are going to increase in the next 25 years. I think what's most striking is that Africa is probably the continent that's going to witness the biggest increase in non-communicable diseases. And so historically, we used to think about HIV, TB, and malaria being the leading causes of death. But it is projected that, even currently, deaths from cardiovascular diseases as well as deaths from cancer are the leading causes of death in Africa and other low and middle income countries. I think our health systems are very well equipped to address non-communicable diseases, infectious diseases, but very ill equipped in dealing with the complexity of non-communicable diseases. And so I think this is an area where the WHO is stepping up. This year's World Health Assembly is focused specifically on non-communicable diseases and helping countries develop non-communicable disease plans. And I think this is important because when we think about non-communicable diseases, there's sort of different layers of approach. There's sort of primary prevention, secondary, tertiary, and then also thinking about how the legislature and the healthcare infrastructure can be built to support it. And so I think it's where we are currently in Africa is that we're ill-prepared in most African countries to deal with non-communicable diseases. I think there are really good guidelines on how we can approach it using WHO recommendations that can be followed. I think the biggest challenge, I would say, is data. I think there's a lot of data lacking on the non-communicable disease prevalence and burden in African countries. And I think this is an area that we need to build so that our interventions can be informed by local data in the country. There's also the lack of healthcare infrastructure and personnel that we'll get into. But I think we are definitely at a healthcare crisis point where we're seeing more non-communicable diseases, but very ill-equipped to deal with it in our setting.
Thank you so much for that. Jacqueline Davis, Princess.
Thank you, Farouk, and thank you, Dr. Yehuda, for that. I think you've covered most of it. One big challenge that I would say in practice in healthcare, and particularly when it comes to the link and the management of non-communicable diseases, is as if our health system also relied on funding, which funding came, external funding that's based on communicable diseases. And now when the non-communicable diseases started going up, we had the nutritional transition, and now we are currently at a verge where food security and food safety is among the big issues. We have a lot of processed foods or a lot of food which is not which is available and maybe cheaper, which is not healthy. Even in areas in Africa where we expected that food production would be good, but then again, the infrastructure built in our African countries right now is focusing on expansion, let's say residential building, and therefore all the lands that where people would do maybe they would create pitches, they will do sports, that was also not somehow all part of the culture. So now it's like we're fixing the plane while it's already flying, and we already have these resources which are limited. The communicable disease burden is still high. We have outbreaks every now and then in Congo. We have in Rwanda, in East Africa, we've seen most in the last, in recent years. So that all still stresses much. But again, our health system funding was not equipped and was not ready for non-communicable disease care. So based on an out-of-pocket or government payment, and now we have to develop insurance schemes, which also have to be maybe relying on the government or private, which is also very expensive. The care for non-communicable diseases is very expensive. I'll give an example. In Tanzania, the care for cancer treatment is actually just out of pocket. It's purely out of pocket. And we only have one hospital that provides the service. So that really, that provides maybe chemotherapy and radiotherapy. So that really stresses much, and the health system is really weak, and can, as Dr. Yoda said, it's really hard to incorporate all these interventions into a proper or better management and addressing of non-communicable diseases. Thank you.
I see Princess is unmuted, Dr. Champong.
Yes, greetings to you all from Ghana. I have my Ghana flag. We had our 68th Independence Day, and so greetings from Ghana. And in my Kente sash, just to say how proud I am of Ghana. However, let me start with a simple story of an encounter I've ever had. So I once met a woman who had come in with a very high sugar readings, and so I engaged her and I told her that, you see, try to counsel her on how she could limit some of the foods and the portions she's eating and all that. Then the woman told me that, oh, you see, my daughter, I've really suffered to take care of my children. And now they are all living abroad. Some are in the US, some are in the UK. And so they send me all these processed foods. I have sardines. I'm able to make good food for myself. So I think it's time for me to eat rich. And so this is what the picture is like. Are people really, do they really understand what is going on? Are they really aware? I think, is there data to back all these non-communicable diseases we are talking about? Have we gotten people to really understand that the non-communicable diseases is the next pandemic as is being projected? Do we have the capacity? Do we have the data? Dr. Yehuada and Jacqueline have mentioned these. And so the bedding is something that Africa, I don't think we have really seen what the bedding is looking like. So there's so much to do. And I believe that these conversations are very healthy for us to kick in to see how we can best help our continent. Thank you.
Thank you very much.
David,
Davis,
go
go
ahead,
ahead, please.
Yeah, thank you all for having us. It's truly a pleasure. And not to echo what has already been said, there's one thing that I have observed over time, and probably most of you. It has not yet gotten into the point that every sector feels to be part of the problem, also part of the solution. So for most countries, but if I cite Tanzania as a good example, it has almost to 90, almost to 100%, it has remained as the sole responsibility of the Ministry of Health to develop intervention and also implement them. But again, if you have to trickle down to the source of the problems, we see that a lot of NCDs are actually attributed by the factors that arise from other sectors. For instance, you talk of nutrition, you talk about industries and agriculture to be contributory, but again, has been a lack of a mechanism by which all these sectors are coordinated. And furthermore, we don't really have clear policies stating about how these risk factors such as tobacco, alcohol should be regulated. And for that matter, is as if the countries and the government and regulatory authorities are more inclined into treating patients rather than tackling, the root causes of the problem. So I find it to be, I know it's not only for Africa, it's across the world, but at least we have evidence, for instance, from some of the Scandinavian countries where like strict policies on tobacco and alcohol consumption have really contributed to the decrease in the incidence or mortality related to NCDs. And the other thing that maybe remain as a challenge is, in our context, and if you go back again to the history, we have been battling with infectious diseases for decades. And in a way, our system although have not managed to even to reduce the burden of this condition, but they have been more invested into dealing with infection. So now we have NCDs, and with the NCD, the main challenge comes, how do you integrate the program that have been operated in silos, where you have a separate program for malaria, which has its own set of funding. You have HIV program, which is also funded independent from TB. But now you have NCD, which is like, you have 1,000 of them. So bringing them into under one blanket and leverage the same funding, the same individuals and the same system into managing and tackling all, it becomes really a huge challenge. But last, which has also somehow been mentioned, we talk about, again, these programs are what we call them vertical programs, which rely heavily on donor funding. And with the donor funding, the priority hasn't been so much onto NCDs. So these countries really struggle much into seeing how they can also mobilize, they can also leverage the same resources into dealing with NCDs. And hence the current situation that we observe in Africa. Thank you.
Well, thank you for those insightful comments.
I wanted to kind of build upon what you guys are saying, especially that that insightful comment about trying to bring budgets together to kind of serve populations that will have more than one disease and will need more than one service. Like, we sit here at the Children's Hospital and I want to bring your attention to pediatrics, because I think it's one of those issues where, again, we think about childhood pneumonia or malaria, like diseases like one at a time. But as we move into non-communicable diseases, we're talking about childhood cancer that it's sometimes or oftentimes neglected as being rare, and congenital anomalies, congenital heart disease, congenital renal disease. So do you see that appetite for kind of subspecialization or that appetite for that kind of services that require extra coordination, maybe only one center per country, or one per, even more regional than just country-wise? Do you guys see a movement towards that, or do you see a lot of barriers to move in that realm?
Yeah, I think that's been one of the biggest challenges, is having these siloed systems that deal with specific disease areas. I think what's going to be needed with non-communicable disease is a restructuring of the healthcare infrastructure. I envision more of a hub and spoke system whereby there are specialty centers for dealing with specific, very highly specialized diseases. And so there can be a specialized cancer center. But in terms of screening for cancer, like, can we screen for common cancers the same way, in the same place that we screen for diabetes, in the same place that we screen for, and so basically building the primary care infrastructure. I think when I look at Botswana, we've done a good job in building the healthcare infrastructure for HIV screening. People can get screened for HIV close to their home. You don't have to travel far to do this. And so can we layer on this primary prevention? Can we educate people in the primary care sector to be able to do some of these screenings? Because I think non-communicable diseases are a package, sort of, in the way we disseminate it, would have to be integrated into the primary care system. I do think you cannot have the specialist pediatric hematologist in every little county in Ghana or in Botswana. And so I think that there is a need for specialized systems. But I do think that at the base of it should be a very strong and robust primary care healthcare system that does screening for non-communicable diseases that are also informed by the country's epidemiology, right? And so if you're seeing more hypertension, diabetes, I mean, these are basic, but you should be screening for things that you commonly see in your setting. Prostate cancer is a bit debatable in the US because it's sort of shared decision-making and risk analysis. But if you're in Ghana, where a lot of men, African ancestry, are diagnosed with prostate cancer early, it's a no-brainer that this should be included in the primary care package. And so I think we do need a robust primary care infrastructure, and then we need great patient navigation. And so patients, we know that screening is just the beginning of a long pipeline of connecting patients to care. And so patients who are then diagnosed should be able to be navigated to a place where they can get adequate care. The issue of funding is a huge, huge barrier. I know there's a WHO initiative specifically for pediatric cancers. And so I think there are certain small, rare cancer groups that might be amenable to a global fund mechanism. And so the WHO infrastructure is to basically fund all of pediatric cancers around the world, so children do not have to die of cancer. But I think the barriers would be with other disease areas and really getting commitment from governments to be independent in terms of funding our own healthcare for our own people.
Okay, just to add to what Yehoda was just saying, building up on the primary healthcare. For instance, in Ghana, we operate from the primary healthcare levels. We have the CHIPS compounds, which are basically serving the most rural areas, and having the sub-district hospitals, the district hospitals, and then the tertiary hospitals. And for looking at non-communicable diseases, I think equipping the healthcare system right from the primary healthcare level, the CHIPS compound, getting people to screened right from that point, that primary point, is very important. I think that some of the data we are losing is because we don't have all these primary healthcare centers equipped enough to detect some of these cases. We don't have people, the questions being asked, the appropriate questions being asked. So we skip a lot of people who are not screened, and so we let them go. But if we do vigorous screening processes right from the beginning, we will be able to get a lot of cases, and then we can start the education, the awareness as well, to get more people involved right from the rural community setting up until the tertiary. We are always looking at the very big picture, the big place, but we forget that there are people at the base who do not even know, they are not even aware that we need to go and screen. Do we sit there to see the bigger symptoms before we move out? I think that we focusing also on at the rural community level, the primary healthcare levels, which are the CHIPS compound, the sub-district levels, they are also a good way to go for us with NCDs, and particularly cancer. Thank you.
If I could also add on to the point that have been said. So I have to acknowledge the fact that some initiatives are already in place, into establishing centers of excellence for managing our NCDs. For instance, in Tanzania, we already have one center of excellence, particularly for cardiovascular science, and there's an ongoing initiative for a similar center of excellence for cancer. I understand the same has happened in some other countries, but again, while envisioning having this big center, we need to address one or two important things. The main challenge might not actually the treatment of this patient, because there are countries in Africa, for instance, South Africa, and also in Tanzania for the case of cardiovascular, have relatively advanced, they offer relatively advanced care. But the main challenge is, how do you get people from the community, linked to the health services? We often receive patients with any of NCD at already an advanced stage. So whether you have the centers or not, once a patient is already at that stage, you find that there's a very little that can be done. So I would rather emphasize on investment, as my colleagues mentioned, on the primary healthcare, making sure that we are able to capture these patients as soon as they develop NCD, for instance, hypertension, etc. And in that way, we also minimize the complication, but also we minimize the cost. You might all have read or come across the pertinent finding regarding the health system in Africa that in general is struggling. And the main issues are, you talk about the infrastructure, you're talking about the financial investment. And now if you bring in NCD where the care is long-term, the most cost-effective approach to me would rather not to focus again on the treatment, but rather preventing this population that are vulnerable, population that cannot really afford the high cost for the treatment, which, as Dr. Jacqueline said, is mainly out of pocket, to actually help them not to have the NCDs in the first place, or at least being able to be captured at the very initial stages. Like, so maybe screening, investment on screening and early detection would be the most cost effective in our context.
Thank you to the panelists. I do have one question. I've been hearing that there's a lot of things that need to be addressed, like public awareness or data collection made better. But in face of implementing such big interventions on a large scale in Africa, what are the main barriers that you might face while trying to prevent these non-communicable diseases? If you can explore more this idea, please.
So maybe I can start and share experience from Tanzania. So what we notice on our ground, as the previous speakers have all said, we actually have an initiated community healthcare platform where 7 regions among the 26 in our country have community healthcare workers up to the level of household. But then what happens is which data is being collected. Mind you, this is routine data. Like for ours in Tanzania, community healthcare system is part of the healthcare system. But how is the data collected and how is it propagated up to the government officials or to the policy level? Now that's one thing. So data can be collected either in a quality that does not really tell much, or in a quality which cannot really inform policies. We do have our Ministry of Health has a Directorate for Preventive Services and an NCD program service. But then the Directorate for Preventive Services actually surveils data. Now, even in this age, still most of the data that gets greatly analyzed on a day-to-day basis is communicable data. So that really breaks it. So the political will and I think initiatives that really bring into light the communicable diseases are pretty lacking. But then again, we do have various initiatives in the country like the NCD week on the first week of November every year, where every region has to prepare screening for non-communicable diseases. If somebody is found there, then referrals in that 1 week. But then again, they occur once in a year. So we would try maybe to integrate these services, maybe when we are commemorating Women's Day, when we are commemorating, but there is no sustainability. And who follows up whether these people actually get to the hospitals? So there isn't like an established system that really captures the data. And should there be, we do have an NCD registry right now in Tanzania, but then it's only functional in places where people are actually willing to do it. So whether facilities or regions where people have actually taken the initiative themselves. So just like the way non-communicable diseases are lifestyle or have many modifiable risk factors, we really need policymakers and people in the health system who really understand what should we do and policies which allow us to get that. Getting public health data is not easy as well. So even if somebody was to analyze it, that's going to be a process. So I think there are really various barriers in terms of mainly would be policy, because policy now defines how you get to channel these services and how you provide them. Thank you.
I think this is a really great point. I also just wanted to add that there is a huge element of culture, right? So I think just growing up in Africa, if you're not sick, you don't go to the hospital. Like there's no culture of prevention. If you're walking, you're talking, you're going to the market, you're getting around, you're well. So then you have these stories of people who like suddenly died. Oh God, they were so healthy and they died. And so I really think, I can count the number of times my parents went to the hospital. I think there's really no culture of primary prevention. There's no culture of you're not sick, you go to the hospital. And maybe we don't have the primary care infrastructure to deal with the burden of everyone suddenly having a PCP or someone to go to. But I think we do really need to change the culture through education, letting people know that you could die of a stroke because you've had uncontrolled hypertension that was asymptomatic, quote unquote, for, I don't know, 5 years, 8 years. But I think there needs to be a culture of non-communicable diseases are different. Like you have malaria shows, you go to the hospital. I think we've definitely been framed to think about illness as something that manifests itself right away. And non-communicable diseases requires us to change that culture and realize that you do need to do the work in prevention to prevent the comorbidities that happen later on. And so I definitely think you'd mentioned, Jacqueline, about community healthcare workers. I think we use community healthcare workers in a lot of the destigmatization around HIV testing. And so I think if we can have community healthcare workers powered to have kept, like a point of care glucose testing, and they screen for blood pressure, and they just do these things around neighborhoods where people actually know them and trust them. That might be one way where we actually think about this as a disseminated process, but then data is collected more centrally. I also think in terms of culture, there is an important point to be made about education on risk factors. So I think someone has said, you live in rich, right? Like people who have a higher BMI in Africa are living a good life like you. And so I think there's a lot of culture that needs to be changed. People have to be made aware that these are like obesity is a risk factor for cancer, is a risk factor for cardiovascular diseases, smoking, alcohol. I think there's a lot also that the private sector is pushing into Africa in that they're promoting, tobacco smoking is probably highest in Africa in terms of increasing rates of tobacco smoking. And so I think just changing the culture, changing the narrative, but it really takes a lot of reframing because in a country, in a continent that has been, has a history of poverty and people being emaciated or thin, or, there is a culture that if you're doing well, it reflects on how you look. And so I think really critically addressing some of this and healthy eating and physical activity are things that seem like easy targets, but actually take a lot of cultural reframing to address it appropriately.
Yes, so just to emphasize the point on culture, just like the scenario I created from the beginning, Africa, we are so deep in our sociocultural beliefs. And so we are socialized with that. And a lot of things are spiritualized. We haven't gotten to the point of thinking that seeking healthcare like immediately is the way to go. So we wait. Actually, people are wait till they see symptoms before they move on. So the awareness creation, I think it's one of the biggest things we can do. It has to be vigorous campaigns from the primary healthcare levels, as I mentioned. So we have our community health workers involved, every healthcare worker at every point. I think that emergency hasn't been created yet. We are speaking about it, but we haven't really created that emergency awareness enough. It is bigger than we are thinking. We are adapting different lifestyles as Africans, and we are not seeing how it is eating us up. So for me, I think that we need vigorous campaign. We need to hold each other, even as Africans, collaborative efforts to rise up and to amplify the burden of NCDs enough, and looking at how it can overwhelm us within the few years to come. So I think that we need to take this as an emergency in Africa. Thank you.
Yeah, maybe if I could also add, I think most of the time we also miss a big picture. We talk of NCDs observed in the adult population, but again, NCDs is a result of many things that have been accumulated over 20 years. So you're talking of people first being exposed to the risk factors when they're young. But again, when we're implementing awareness campaigns, we are targeting people who are already at the verge of developing the NCDs. So it means we will always be, we could all most often targeting a population, not entirely wrong, but approach could be wrong, because again, the young people are in schools and we don't go to the schools, we don't have curriculum which have incorporated NCD awareness or NCD's knowledge. So at the end of the day, by the time these people have the first encounter on awareness campaign, they already have accumulated a lot of risk factors. So I think we just need to reinvent the way we approach the affected population, prioritizing young people as well. And maybe most of you may have seen that at least in the current decade, we are seeing a very alarming increase in NCDs in young people. We're talking of people as young as in their early 20s, late 20s, early 30s, already have cancers, already have hypertension, and that should alert authorities on how best to prioritize the intervention. Yeah.
Thank you all. Thank you all for the discussion thus far. I did have a question. I mean, we've discussed, the importance of prevention for NCDs and how sometimes, for governments that have limited budgets and unlimited priorities, how can we think about incentivizing governments and the private sector to invest in NCDs, both in prevention and management, and in some cases, the long-term management of some of these chronic diseases, such as cancer?
I can go first. I think it is really important to understand what benefits each party. So the government has its own set of priority, and so is the private sector. So if the approach is to engage the private sector in a way to incentivize them into taking any initiative, you really need to understand the private sector are into reaping benefits. So in this situation, if you want them to be fully engaged, you should be talking about things of taxation. If at all these companies are given things like tax breaks, they are more likely to be committed into this initiative. But again, there is also initiative that has been implemented in several countries that they talk of, I think, is Social Responsibilities Act, where each a private firm is supposed to conduct its intervention, its initiative in a way that it also benefits the society. So if at all our policies are developing in a way that some of their social responsibilities should be to addressing the NCD, then that would could be one of the suitable or the best approaches. But in case of the government, so the government you are talking about, the policymaker, these are the people primarily elected by the population, and they are more into the impact, things that really have contribute to the efficiency of the government. So the way we can get the government fully on board, we really need to present evidence that show what are the economic benefits of let's say investing in NCD prevention. You are talking of Africa having 40% of its population as young people who are inherently at the risk of NCD. So it means if we prioritize this population, we are talking about saving the next generation of productive individuals that could contribute to the economy. So I think we need to come up always with initiatives or with the strategies of engaging the parties that contribute to the efficiency, and in a way we can, we can somehow curb the rising burden of NCDs. Thank you.
I just want to add very brief. Oh, sorry. I just wanted to add very briefly to that. In that, I don't think, I think there's a legal framework for this, which is that healthcare, like ensuring the healthcare of your population, is a basic human right. And so I think at some level, our governments are responsible for making sure that the population has adequate healthcare. And I think, to your point, we cannot prioritize everything. But I think this is where data is important. We need to understand, like we can treat pancreatic cancer and treat breast cancer and cervical cancer. And, I think we have to decide what cancer types or what non-communicable diseases are affecting most of the population and prioritize that, because there's no way ministries of health can cover all of these. I also think there's a point, like Davis said, to be made for economic development. I don't think any country has attained high economic development without actually, improving the healthcare of its population. And so I think if we want to economically advance, we have to make that initial investment. There's no way we're going to be, superpowers in the world with a population that's, dying from all of these communicable diseases at an alarming rate. And so I do think that there's an economic argument to be made for that. And but I also think there's a legal framework, which is that, there is a basic human healthcare right to adequate healthcare. I mean, we could talk about things that are going on in our backyard, but I think in general, there's a legal framework to support the coverage of healthcare for our population.
Awesome. This has been a great conversation so far. We're getting to the end of it. And so we're just gonna try to take one question from the audience. Fortunately, we can't answer all, but this is a specific question from Abbas. Is there a mechanism where African countries can purchase critical medications as a block to ensure affordable access to medicines? Maybe Yehuda, you can start since you're the...
Yeah, so I think there are a couple of initiatives around cancer. I think they're probably translatable to cardiovascular diseases as well. So PAHO, the Caribbean region, all do pooled procurement, realizing that a lot of African countries are going to have very small populations with specific cancers. And so if we can procure medicines as a region, we can actually use economies of power to negotiate lower rates for a lot of cancer medicines. And so this is something that's ongoing, and there's a question about, whether this can be done through the AU. I think it's a lot of it is just going to be, breaking down the political silos and actually generating political will from people to want to be involved in this process. The UICC, so the Union for International Cancer Control, and the WHO and some other private sector partners are thinking about creating a market for ministries of health where any ministry of health can purchase medicines directly for cancer medicines that have been negotiated or donated through some program. But it'll be sort of a central repository or marketplace where countries that can then purchase into. There's an implementation project going on for 5 different countries. And so we'll see how that plays out. I think all of these, in order to be sustainable, will require a huge financial commitment from ministries of health. So some can be donations, but in the long term, it has to be also supported by ministries of health.
Anybody else? Okay. Oh, Davis, go ahead, please.
Okay. So there is, as Dr. Yone mentioned, so there is this African, I think, full initiative on procurement of pharmaceuticals. So although this is an initiative that was actually introduced and approved by member countries of the African Union, the challenge has been that it has not been a binding agreement. So that means despite being in place, there are few countries that are strongly in favor of the initiative, and although it has already been validated by WHO, but again, very few countries use that mechanism in procuring the medication and everything. So again, we go back to the issue of the priorities and the political will of the countries in a way that they can leverage the strength of one another to making sure that the population in Africa can benefit the most. So it's an ongoing initiative. Maybe we are hoping with the newly introduced initiative of Free African Trade Initiative, maybe that could also materialize. Thank you.
Great. Well, this has been a great conversation. Unfortunately, we don't have all day to go deeper into these topics, but just want to thank the panelists on behalf of our team here for sharing their insights. We as people who work in the imaging space, we're oftentimes not exposed to conversations like this, even though radiology has a significant role to play in, dealing with non-communicable diseases. Obviously, proper diagnostics is probably one of the most important considerations in managing these patients appropriately. Radiologists are experts in the field of artificial intelligence and data management in general. So we do have to be aware of these topics in order to be able to participate in advancing healthcare in our countries. And so thank you very much. I'm handing this over to Mo to get us started on the next part of our program, the presentations of the cases.
Thank you for having us.
Okay,
Thank you
thanks,
for having
Jennifer.
Thank you.
Thank you.
Thank you all. We appreciate your time. So now we will transition to the awaited case presentations. Starting from Liberia, we got a very interesting case and a very rare one as well of a boy with short lower limbs by Dr. Eugene Coleman Nekar.
My name is Yechon Komonaka. I'm a pediatric fellow working at the JFK Medical Center, Monrovia, Liberia. My consultant is the Dr. Betty Goffer. I'm presenting a rare case of a boy with short lower limbs. Patient is a 14-month-old male toddler who presented with abnormally shortened lower limbs since birth and excessively mobile limbs since birth. The pregnancy was unremarkable. There was no antenatal ultrasound done, and there was no history of drug use during pregnancy. Patient feeding history was inadequate for his age. He had only one immunization since he was born. There was no family history of previous similar occurrence. His developmental history was normal except for gross motor delay because of the deficiency. He was malnourished, however, he was in no apparent distress. His anthropometric measurements were all less than -3 standard deviation for his age. His upper segment versus lower segment ratio was 2.2, and the normal for his age is 1.35. In line with his limbs hyperadducted, with this bulkiness seen at the proximal part of his lower limb, and he had club foot bilaterally. On imaging, he had bilaterally short femur with absent femur head and a deformed pointed proximal end. There was shallow acetabulum seen in the proximal. The femur length on the right side was 3.5 centimeters, while on the left side it was 3.1 centimeter. On further skeletal survey of his lower limb, he had both fibula present. His X-rays for his spine and his chest were all normal. We had a diagnosis of bilateral congenital proximal femoral focal deficiency. PFFB is a rare congenital abnormality characterized by failure of normal development of the proximal part of the femur and also the acetabulum. The etiology of this condition is unknown, but some literatures have postulated that it may be related to thalidomide exposure. It occurs unilaterally in 85 to 90% of cases, with a frequency of 1 to 2 per 100,000 live births. In also 50% of cases, there is absent fibula. PFFB is classified based on the acting classification from A to D, with A being the less severe cases and D being the most severe case, where there is absent acetabulum, no femur head, and a very small deformed femur. Excuse me. For treatment purposes, PFFD can be classified into 3 groups: mild, which requires limb lengthening procedures, types A to C for under the group 2, which requires more extensive surgeries, including rotational plasty, knee fusions, and then prosthesis. Group D, group 3, which includes group D, requires amputation and use of prosthetics fittings. when a condition is bilateral, then now you need more counseling and discussion with the parents on the methods of the modalities of treatment, because these are very intensive procedures. Recommendation is for early detection and diagnosis, because of the optimal goal of early detection and treatment is for the child to be ambulatory. For our case, we had a patient with type D in bilateral congenital femoral and focal deficiency, which is the very severe form that is now occurring bilaterally in the patient. These are my references, and thank you for listening.
That was a very interesting case from Liberia. Moving on to Nigeria, a unique challenge in Mayor Rokitansky Kotzer-Hauser, I always pronounce this wrong, syndrome type 2. Dr. Chinaza Kalaiwo. Let's see what we have.
Good day, everyone. My name is Chinasa Kalaiwo. I am a radiology resident from National Hospital, Abuja, Nigeria. I'll be presenting a unique challenge in Mayor Rokitansky Kuster-Hauser syndrome type 2. Our index patient is a 24-year-old female who presented with a history of primary amenorrhea with complaints of dyspareunia and failed penetrative intercourse. She reported cyclic low abdominal discomfort since adolescence, but never experienced menstrual bleeding. There was no significant past medical or surgical history. No history of childhood illness necessitating radiotherapy or chemotherapy. Following presentation, she had abdominopelvic ultrasound scan, magnetic resonance imaging, and laboratory testing done. On physical examination, she had hirsutism, symmetrical Turner stage 4 breast development with galactorrhea, normal external female genitalia, and a 4 cm blind ending vagina. Hormonal profile showed low gonadotrophin levels. There was no biochemical evidence of androgen insensitivity. Abdominopelvic ultrasound scan indicated the absence of the uterus with a solitary right normal sized kidney. The liver, the gallbladder, the pancreas, and the urinary bladder showed normal morphology and were well within normal limits. These findings noted on the scan were confirmed on the abdominopelvic MRI, which is sensitive and specific for diagnosis, as it clearly delineates the surrounding anatomical structures better. This is a coronal T2 weighted magnetic resonance image of the abdomen, clearly showing the solitary right kidney in its normal anatomical position on the right renal bed. We can also appreciate that the left renal bed is empty. These are sagittal and coronal T2 weighted magnetic resonance images of the pelvis, showing the empty uterine bed, with the yellow arrow indicating the position, the anatomical position where the uterus is supposed to be. There is, however, no mass or any abnormal signal intensity in this location. The green arrow highlights the rudimentary vagina. These are sagittal and axial T2 weighted magnetic resonance images of the pelvis, showing the right ovary posteriorly and the left ovary anteriorly. Following testing and diagnosis, comprehensive counseling on the findings and the nature of this congenital anomaly, its long-term implication, and proposed management options, which included vaginal dilatation and vaginoplasty, was clearly explained to this patient. It was also highlighted that a multidisciplinary approach is needed in her care, and during the course of management, she will be referred to urogynecology and reproductive endocrinology. This case is unique due to the congenital absence of the uterus, and for which it requires a long-term follow-up to address the challenge of primary amenorrhea and primary infertility caused by this anomaly. Mayor Rokitansky Kuster-Hauser syndrome is a rare congenital disorder of Mullerian duct malformation with an incidence of 1 in 5,000 females. It is characterized by agenesis of the uterus and the upper part of the vagina in women, showing normal development of the external genitalia and a normal 46XX karyotype. It could be isolated in type 1 or with other additional extragenital malformations in type 2, involving most commonly the kidney, which could present as ectopic or agenesis, as seen in our index patients. The skeletal and vascular systems can also be affected. This syndrome is important because it poses significant reproductive and psychosocial challenges in affected females, so early diagnosis is beneficial. For this reason, clinical examination and radiological imaging should be done if menarche has not been achieved by the age of 15 years. In addition to the surgical and non-surgical treatment options, proper counseling is required for psychological and social support. These are my references. Thank you for listening.
Thank you, Dr. Kalaiwo, for this interesting case. Moving on to Zimbabwe with Dr. Preference Mangwayana, presenting a prevalence of the intrauterine fetal demise in pregnant women with pregnancy-induced hypertension.
Compliments of the good day to you all. My name is Preference Mangwayana. I'm in my part final doing bachelor's degree in radiography diagnostic at the University of Zimbabwe. My mentor is Mr. Tabani Mutombe, the senior radiographer at Paranyata Group of Hospital. Today, I am delighted to present my case study entitled Prevalence of Intrauterine Fetal Demise in Pregnant Women with Pregnancy-Induced Hypertension, which is in alignment with the theme Non-Communicable Disease. Literature proves that pregnancy-induced hypertension has become the worst non-communicable disease globally, in which 6 to 8% of pregnant women experience PIH globally and contributes to maternal and perinatal mortality and morbidity. There are two parameters for PIH, which is systolic blood pressure of greater than 140 millimeters of mercury and diastolic blood pressure of greater than 60 millimeters of mercury. In my case study, I discovered that 60% of women who experience PIH have a similar social background of advanced maternal age, low socioeconomic status, lack of education, and also they have clinical history of decreased complete body count and increased liver function tests. The aim of the case study was to determine the prevalence of intrauterine fetal demise among pregnant women with PIH. Through prospective and retrospective cross-sectional study on 500 women with PIH, and the population includes ages from 18 to 45 years. The results were as follows. Out of 500 women, 300 women with PIH presented with intrauterine fetal demise. 105 were able to have normal delivery term. 50 were induced at 35 to 37 weeks due to abnormal doubles, and both fetus and maternal survived. 45% of the population lost their lives before 33 weeks. Ultrasound findings were fetal growth restriction, presenting as small for gestational age with abnormal fetal and maternal Dopplers, oligohydramnios, abnormal fetal movements, or absence of fetal heart rate. So this is the image of head circumference of a fetus whose maternal is pregnancy-induced hypertension. The head circumference is showing gestational age of 32 weeks, 4 days, which is less than 1 percentile, instead of showing 36 weeks, 1 day. We can see that the fetus is being restricted to growth due to pregnancy-induced hypertension, and these are the structures we expect to see in the head circumference of a fetus. And also, this is the image of abdominal circumference of a fetus whose maternal is PAH, and we can say the estimated fetal weight is giving the fetus the gestational age of 22 weeks, 6 days, which is 5.8% here, instead of showing gestational age of 24 weeks, 2 days. And also the fetus amniotic fluids in deepest vertical pool is less than 2%, showing oligohydramnios. So we can also see that the fetus is restricted to growth due to severe PAH. And also this is the image showing maternal abnormal left uterine Doppler, which is presenting with hypofertility index of 2.1 and due to high peak systolic and notching on diastolic. This is due to decreased blood flow and oxygen delivery to the fetus. So for treatment, they should be monitoring blood pressure and urine protein at regular intervals. Also, antihypertensive should be offered. Also, corticosteroids should be offered to promote fetal lung maturity. On discussion, although PAH is one of the worst non-communicable disease globally, proper management on high-risk pregnancy and those with confirmed PAH is important to avoid the intrauterine fetal demise prevalence, which is at peak globally. This should be through early screening at first trimester, and also there is a need for interventions to prevent intrauterine fetal demise in women with PAH and high-risk pregnancy. I believe if we join hands together, we can reduce the occurrence of these non-communicable disease globally. These are my references. Thank you for having me today.
Thank you, Dr. Preference, for this interesting case. This was a submission from Zimbabwe. Now moving to Ethiopia with Dr. Lul Adane, presenting a primary hepatic pregnancy, an extremely rare location and an intra-abdominal ectopic pregnancy.
My name is Lul. I'm a pediatric radiology fellow in Addis Ababa University from Ethiopia. I present you a case of primary hepatic pregnancy, an extremely rare location of intra-abdominal ectopic pregnancy, diagnostic and management challenges. Refers to the implantation of the gestational sac directly on the liver parenchyma. It constitutes only 0.03% of all ectopic pregnancies. This condition poses significant diagnostic and therapeutic challenges due to its atypical clinical presentation. 35-year-old para-1 woman presented emergency department with a 6-hour history of severe abdominal pain and 3 months of amenorrhea. Months ago, she visited the hospital and had a positive urine HCG, but ultrasound didn't show intrauterine or extrauterine pregnancy. On physical examination, she was tachycardic and had pale conjunctiva, slightly distended abdomen, and diffuse tenderness, more pronounced on the right hypochondria. And the serum quantitative beta HCG result was significantly raised. On abdominopelvic ultrasound, the uterus was empty, udinexia were free, and there is gestational sac in the right hepatic lobe containing a singleton fetus with positive fetal heart rate and gestational age corresponding to 12 weeks. And there was moderate free peritoneal fluid. Longitudinal scan of the pelvis showing empty endometrium and minimal load. And a longitudinal scan on right upper quadrant showing a gestational sac with fetal pulse and free fluid in Morrison's pouch. Dynamic ultrasound image shows gestational sac in the liver with active fetal heartbeat and fetal tone. primary hepatic pregnancy was suspected, and to ascertain the precise location of the pregnancy, CT scan was done. A sagittal CT scan showing gestational sac in the liver parenchyma and the crown to rump lengths measuring 5.6 millimeter. This axial and reconstructed coronal maximum intensity projection image showing blood supply to the gestational sac from the right portal vein and a branch from hepatic artery.
This CT scan is an accompanying case, a 23 years old female. An axial sagittal CT scan, you can clearly see the gestational sac in the liver parenchyma, mainly in the right posterior segment. This is the second trimester. You can clearly see the head, ossified bones of the fetus, the spine and the limb. And also on the sagittal CT scan, this is the head, chest region, upper limb, and the femoral bone. With the progress of the pregnancy in the second trimester, the bone gets mineralized and appear more conspicuous on CT scan.
When we come to the management, PO mifepristol was given, and the ectopic pregnancy was located in the right posterior inferior segment of the liver, and a gestational sac was accessed and removed. The right lobe of the liver was mobilized. The hepatoduodenal ligament was clamped to limit blood flow to the liver, and wedge segmental liver resection was done. The microscopic image of tissue from the resected liver showing the chorionic villi and cytotrophoblast infiltrating into the hepatic tissue. After 2 days of hospital stay, patient discharged home with stable vital signs. Oral antibiotics and analgesia was given, and serum HCG level was normalized after 3 weeks of discharge. On discussion, the potential mortality rate associated with hepatic pregnancy is reported to be 5 to 7 times higher than that observed in other type of ectopic pregnancy. Diagnostic delay elevates the risk of complications, and early abdominopelvic ultrasound is instrumental in expediting the diagnosis. The take-home message from this case is to emphasize the importance of maintaining a high index of suspicion for rare ectopic pregnancies when patient present with atypical abdominal symptoms. Timely diagnosis and intervention are important as the potential for severe intraperitoneal hemorrhage significantly increases maternal morbidity and mortality. Therefore, a proactive approach that prioritizes early recognition and management is vital to improve outcomes. Thank you for your attention, and this was my reference. My name is...
Thank you, Dr. Lul. Moving to North Africa now with a case from Tunisia, Dr. Nader Gharbia will be presenting about the upper urinary tract tumor in a horseshoe kidney with pilourethral junction obstruction.
Dear esteemed professors, colleagues, and friends, I am Dr. Nader Gharbia, a urology resident at La Rabta Hospital in Tunis, Tunisia, and I am honored to present our case titled Unique Conversions, Upper Urinary Tract Tumor in a Horseshoe Kidney with Pilourethral Junction Obstruction. I am delighted to share this rare and challenging case with you today, focusing on its particularities and the multidisciplinary approach we employed. We don't have any disclosures. So a 66-year-old male patient, a heavy smoker with limited socioeconomic status, presented to our urology department with isolated right flank pain persisting for 6 months. Notably, the patient reported no history of hematuria, chronic fever, or other urinary symptoms. Furthermore, there was no clinical signs of paraneoplastic syndrome. On clinical examination, we palpated a solid massive abdominal mass extending from below the left rib cage to the lower abdomen. General laboratory investigations were within normal limits. To further investigate, we performed an abdominal CT scan which revealed a neurological anomaly. The horseshoe kidney, rare congenital fusion of the lower renal poles, Additionally, the imaging showed left ureteropelvic junction obstruction leading to massive hydronephrosis with dimensions measuring 26 by 24 by 23 centimeters. We observed segmental thickening of the upper urinary tract, which raised suspicion of an underlying pathological process. As you can see on the image, there was prominent focal enhancement with Hounsfield unit values increasing from 66 to 93 and from 44 to 84. These findings were suggestive of a neoplastic lesion, and active surgical treatment was indicated. Given the anatomical complexity, we conducted an assessment of the tumor's vascular variation to guide our surgical approach. CT revealed one artery on each hemikidney. As shown on the slide, both arteries originated on the right side. The artery supplying the right hemikidney was in its usual position, while the artery of the left hemikidney was located lower, just above the aortic bifurcation. Given the complexity of the case, an open left heminephroureterectomy via midline xiphopubic incision was chosen. We mobilized the transverse and descending column to reach the left hemikidney within the retroperitoneum. A large mass was identified. We performed a meticulous dissection to isolate the isthmus which was ligated. The renal pedicle posed a considerable challenge due to its difficult access. After careful dissection, we successfully ligated the renal pedicle and the hemikidney was removed after a bladder cuff excision. The mass weighed a remarkable 8,000 grams. We estimated 500 milliliters of blood loss, and the postoperative course was uneventful. Now let's move to the discussion of our case. Horseshoe kidney is the most common renal fusion anomaly, with a prevalence ranging from 1 in 400 to 1 in 800 in the general population. The anatomical anomaly is associated with an increased risk of complications, including ureteropelvic junction obstruction, urinary stasis, and malignancies, particularly upper tract urothelial carcinoma. Upper tract urothelial carcinoma accounts for 5 to 10% of urothelial malignancies, and smoking is the most significant risk factor for its development. In our case, the patient's significant smoking history and the chronic ureteropelvic junction obstruction likely contributed to the development of the upper tract urothelial carcinoma in the horseshoe kidney. Preoperative imaging is crucial in such cases. Computed tomography urography is considered the gold standard for diagnosis. Moving on to surgical management, it's important to note that horseshoe kidneys present unique challenges due to their complex vascular anatomy with risks of aberrant renal arteries. Open surgery remains the preferred approach in complex cases, especially when dealing with large tumors or significant anatomical variations, as it offers superior access and control compared to minimally invasive techniques. To conclude, there are a few key takeaways from this case. First, radiological preparation is critical. It assists in reducing intraoperative risks and ensures that the surgeon is well prepared for any challenges that may arise. Second, multidisciplinary collaboration is essential for successful outcomes. Effective communication between radiologists and surgeons enhance decision-making and improves the overall management of such patients. Finally, a tailored surgical approach is crucial. For cases involving large tumors and complex vascular variations, open surgery remains the preferred option. Thank you.
As a mentor, and then kind of
Thank you, Dr. Gharbiya. Very interesting case and a huge mass. Moving to Ethiopia with Dr. Yenemub Tesfaye, talking to us about diffuse cerebral calcification caused by vein of Galen aneurysmal malformation.
Hello everyone, this is Dr. Enemulkan from Addis Ababa University, Ethiopia. Currently, I'm a third-year radiology resident at Addis Ababa University, and I'm very grateful for this opportunity. And the case that I have for you today is diffuse bilateral cerebral calcification caused by vein of Galen aneurysmal malformation. My mentors are Professor Daniel Zodina, a consultant pediatric radiologist, and Dr. Takwam Dapaba, a consultant neuroradiologist. I would also like to mention another team member, Dr. Yabsura Lago. I have no relevant disclosure. Coming to the case, this is a 2-year-old male child who presented with repeated episodes of abnormal body movement of tonic flexion of the upper extremities and jerky movements of the lower extremities. For this, he was taken to a nearby hospital and later referred to our institution after he was put on anticonvulsants and he didn't achieve developmental milestone for his age. There is no pertinent family history. On physical examination upon arrival, stable vital signs, the general appearance, he had sunset eyes, and neurologic examinations, sleepy but resolvable to minor stimulation and moves all extremities. Laboratory findings, CBC, renal function and liver function tests were within normal range. Torch infection screening was negative. And on imaging, brain MRI, titulated sagittal and axial images show large aneurysmally dilated vessel in the region of the vein of Gallen with dilated falcine sinus, which communicates with massively enlarged superior sagittal sinus, and the dilated vein of Gallen has significant mass effect on the cerebral aqueduct, causing upstream ventricular dilatation of the third ventricle and the bilateral lateral ventricles. On brain CT, axial and sagittal brain window CT, we see this multiple bilateral diffuse hyperdense foci distributed along the subcortical white matter as well as along the cortex, and on the sagittal image we also see this multiple hyperdense foci in the midbrain. And coming to the disease course and treatment, in vein of Gallen malformation, the aim of treatment is not anatomic normalization, but to control the malformation so that normal development and maturation of the brain can be achieved. And the mainstay of management is endovascular embolization. Unfortunately, in our case, the patient's presentation was late and he had severe acute obstructive hydrocephalus upon presentation, and shunt tube was placed. But later he deteriorated and died 1 day after tube insertion. Vein of Gallen aneurysmal malformation is rare and it accounts for 1 to 2% of intracranial vascular malformation. It represents a direct arteriovenous communication between the deep choroidal arteries and the persistent embryonic precursor of the vein of Gallen, also known as the median prosencephalic vein of Markowski, which was supposed to regress in normal individuals. And the diagnosis is made prenatally on ultrasound and MRI, and in delayed postnatal presentation, angiography is the gold standard imaging modality for diagnosis. Cerebral calcification due to vein of Gallen aneurysmal malformation is extremely rare, with few reported cases in the literature. In untreated vein of Gallen aneurysmal malformation, dystrophic calcification occurs around subcortical white matter, usually bilateral and symmetric in distribution, with other associated findings of subependymal atrophy and ventricular dilatation. It could be asymmetric in shunted patients, more prominent on the non-shunted side of the brain. The cause of calcification in this arteriovenous malformation is chronic venous hypertension and ischemia. So it is seen in those patients who are present late in the disease course. And the differential consideration is torch infection, especially cytomegalovirus infection. But the pattern of distribution of calcification in CMV infection is periventricular white matter with ependymal or subependymal location, and other cystic brain abnormalities will be demonstrated. On top of that, other systemic manifestation of cytomegalovirus infection, including hepatosplenomegaly, as well as Tanis manifestations will be seen. The take-home message for this case is intracranial calcification in pediatric patients below the age of 6 years is almost always pathologic, representing a damaged or malformed brain, like in our case, or a neoplastic process. Although intracranial calcification associated with vein of Gallen malformation is a rare occurrence, it should be considered, especially in appropriate clinical setup. And prenatal diagnosis is very important to prevent late complication, including brain malformation and mass effect from the dilated venous structures. These are my references, and I'm very grateful for the opportunity once again, and thank you.
Thank you, Dr. Tesfaye. Very interesting in their case from Ethiopia. Moving to the representation from Ghana, Dr. Joseph Abedo Wilson talking about a complete cerebellar agenesis in a living person.
Hello, my name is Joseph Abedo Wilson, a radiographer training from the Kwame Nkrumah University of Science and Technology, and I'm presenting on complete cerebellar agenesis in a living person. So a 16-year-old male patient was presented for an enhanced brain MRI scan. Patient had a clinical history of unexplained nasal congestion for the past 6 years and also complained of recurrent headaches as well. Some of the symptoms that are observed from the patient include mild hypotonia, gaiting disturbances, severe intellectual disability, dysatrial, and social anxiety disorder. And prior to this MRI scan, a histology test was done using his nasal sample, and it revealed traces of CSF. And from the family, they had sought herbal intervention in battling the nasal congestion before finally visiting the hospital. The MRI scan was achieved by using a 1.5 Tesla Siemens MRI machine. And with the radiological findings, the T2 images, the various sections of the T2 images showed a complete loss of the cerebellum, and the cerebellar space was completely filled with CSF, and the bright appearance of CSF in this image, as indicated by the arrow, is due to the hyper-intense appearance of fluids on T2 images. And on the T1 and FLAIR images as well, the accumulated CSF appears low appears dark due to the hypo-intense appearance of fluids in T1 and FLAIR images when it comes to MRI, and the arrow in Fig A shows the hypoplastic brainstem, which is associated with the patient's condition. However, the ventricles were unremarkable. And with the diffusion images, it showed no abnormal diffusion in the brain parenchyma. For the Figure A, that is the DWI, and Figure B is ADC. The loculated fluids in the DWI appears bright due to the hyper-intense appearance of loculated fluids in DWI images, and the dark appearance of the accumulated CSF in Figure B is due to the hypo-intense appearance of loculated fluids in ADC images. And with the post-contrast phase, it was achieved by administering 4 mL of gadolinium contrast, which was followed by 5 mL of saline solution, and it appeared that no lesion was picked up for the post-contrast phase, both in the brain parenchyma and the cyanosis as well. So with these findings, the patient was diagnosed as a complete cerebellar agenesis associated with no parenchymal lesion. The complete loss of the cerebellum could be attributed to malformation very early during embryogenesis, which is around the 2nd month, according to literature during embryogenesis. The associated hypoplastic brainstem may also be due to the loss of communication between the brainstem and the cerebellum. And even though the cerebellum is not there, the patient is able to perform some of the functions that the cerebellum is supposed to regulate. And this could be attributed to the compensatory nature of the brain to perform functions of its missing parts. The unexplained nasal congestion, however, is the first condition, is present as the first complete cerebellar agenesis, which comes with associated nasal congestion, and this may be attributed to disruption in the autonomic regulation of the brain due to the absence of the cerebellum, and also the CSF dynamics, as well as it creates intracranial pressure due to the accumulation of CSF in the cerebellar space. The interventional recommendations were genetic testing and a multidisciplinary approach by involving the needful stakeholders in managing the patient's condition. However, due to financial incapacity and the absence of cure for this condition, a conservative individual system treatment was used in managing this patient's case. So for my conclusion, it could be said that cerebellar agenesis is an extremely rare brain anomaly which poses with complex prognosis, due to its controversial etiology. And we could also see the compensatory nature or the ability of the brain to perform functions of its missing parts. And we can emphasize on the role of cerebellum in normal motor language and mental development as well. These are my references. Thank you.
Thank you, Dr. Wilson, for a very interesting case, informative images. Moving to South Africa from Ghana, Dr. Audrey Rumhumha will be presenting a case of a spine tingling case of a common tumor in an uncommon location.
Good day, everyone. My name is Dr. Audrey Rumhumha, a radiology trainee from the University of Witwatersrand in Johannesburg, South Africa. I'm currently in my 4th year of training. Today, I'm excited to present an intriguing case titled A Spine Tingling Case of a Common Tumor in an Uncommon Location. We have no disclosures to report. Written consent was obtained from the child's guardian, her mother. Let me introduce you to our patient, a 9-year-old female with no known comorbidities, who presented to the orthopedics department due to a history of lower back pain. According to her mother, the patient had experienced vague pain in the lower back and gluteal region for approximately 8 months, which had progressively worsened and was associated with weight loss. Despite numerous visits to local general practitioners and several prior radiographs, initial assessments yielded no significant findings. As the pain intensified, a referral was made to a tertiary institution where the child was evaluated by the orthopedic specialists. On examination, vital signs were stable and there was normal neurological function. Notably, a soft tissue mass was palpable in the sacral region. Initial laboratory tests indicated elevated levels of ESR at 40 and LDH at 2,206. The initial imaging performed were pelvic radiographs, which revealed heterogeneous lytic and sclerotic changes in the sacral bones, characterized by a wide zone of transition and surrounding ill-defined soft tissue mass. These raised concerns for an aggressive process. Importantly, no calcifications were identified in the overlying soft tissues. Subsequently, an MRI was conducted. It revealed a soft tissue mass predominantly occupying the presacral space with no evidence of cord compression. The mass was heterogeneous and located anterior to the sacrum and coccyx, with solid cystic components showing high signal on T2 weighted imaging. It exhibited heterogeneous post-contrast enhancement. The lesion was noted to infiltrate the anterior vertebral body cortex, extending into the S2 and S3 vertebrae and into bilateral ischioanal fossa. Furthermore, there was interspinal extension with attenuation of bilateral neural foramina at S3, S4. The mass was compressing on the adjacent pelvic viscera with anterior displacement of the rectum and the bladder. A staging CT scan of the chest and abdomen revealed multiple metastatic liver lesions appearing as heterogeneously enhancing rounded hyperdense lesions of varying sizes as depicted in the CT scan. At this juncture, our imaging differentials for the mass included chordoma due to its location, a sacrococcygeal teratoma being the most common sacrococcygeal mass in pediatric patients and less likely a rhabdomyosarcoma. A biopsy was then performed and it revealed a small, round blue cell tumor that tested positive for the EWSR1 break-apart gene, thereby confirming a diagnosis of Ewing sarcoma. This finding was somewhat surprising to us, as it had not initially been included in our differential diagnosis. The patient is currently undergoing combination chemotherapy and will have repeat imaging post-treatment to assess for potential surgical resection of any residual tumor. Ewing sarcoma is a highly aggressive cancer that affects bone and adjacent soft tissue, predominantly in young children and adults. It ranks as the second most common primary bone tumor in children, following osteosarcoma, and typically has a predilection for long bones in the trunk, making sacral involvement quite uncommon. Interestingly, spinal Ewing sarcoma accounts for only 10% of primary Ewing sarcoma bone lesions, and sacral involvement is even rarer. Most spinal cases are a result of metastases. Diagnosis is often delayed, as symptoms typically emerge only after neurological deficits develop. With the imaging of sacrococcygeal tumors, age and signal characteristics of MRI are essential for narrowing down the differential diagnosis. Although MRI serves as the most effective diagnostic tool, its low specificity in such cases presents challenges in radiological assessment and makes diagnosis heavily reliant on histological examination. Our takeaways and learning points from this case were: Ewing sarcoma, while rare in the sacrum, should always be considered in the differential diagnosis of lower back pain in children. More common diagnoses should be higher up in our differential. Thank you. These are our references.
Thank you. And moving on to Egypt with Dr. Nurhan Mamdouh Al-Nimr, talking to us about angiomatosis in a 10-year-old boy presenting with recurrent pleural effusions.
Greetings, everyone. My name is Nurhan Mamdouh. I am a fourth-year radiology resident. Today, I'll be presenting a rare case of pleural vascular malformation, angiomatosis in a 10-year-old boy presented with recurrent pleural effusion. Under supervision of Professor Shaima Abdel Sattar, Radiology Department, Professor Iman Ragab, Pediatric Department, and Professor Riham Ahmed, Pathology Department. A 10-year-old boy presented to the ER with dyspnea and tachypnea. Chest X-ray was done, showing bilateral pleural effusion. Pleural tapping was made, yet the patient did not improve. Further evaluation by chest X-ray showed recurrent pleural effusion. Subsequently, multiple frequent pleural tapping was made, with some of them showing hemorrhagic effusion, and the patient eventually had pigtail insertion. This is the chest X-ray on the admission day, showing bilateral pleural effusion. 3 days later, after tapping, still noted pleural effusion. It even increased in amount. And at day 10, despite of insertion of pigtail and frequent regular pleural tapping, there is still noted pleural effusion with bilateral alveolar consolidation. The patient then had CT chest with contrast. It showed bilateral pleural thickening with abnormally contrast-filled blood vessels seen crossing the pleura. Then the patient had dedicated chest wall ultrasound, B-mode showing turbid pleural effusion, and with the use of the linear probe, it revealed increased pleural thickness. With the help of the Doppler color and waveform, it showed a large vascular channels that showed both arterial and venous waveform. At this point, a diagnosis of epithelioid hemangioendothelioma versus inflammatory process was made. The patient then was referred for pleural biopsy, and histopathology came with the hematoxyl and eosine staining, proving the presence of variable-sized branching blood vessels, as we can see here, and with the use of the vascular structure-specific stains, such as ERG and CD34, a diagnosis of pleural vascular malformation angiomatosis was made. Before the pathology report came out, the patient developed oxygen desaturation, was put on mechanical ventilation, and sadly passed away shortly. Pleural angiomatosis is a rare non-neoplastic proliferative vascular lesion. It's characterized by diffuse proliferation of the vessels and adipose tissue. It can develop during childhood or adolescence, with the pleural effusion being the first presentation. Diagnosis of pleural vascular malformation can be very challenging, with tissue biopsy being necessary to establish the final diagnosis. Differential diagnosis includes Kaposiform lymphangiomatosis. So take-home message: Scalar Doppler and waveform enhance the evaluation of the vascular lesions. Vascular malformation should be considered in case of recurrent hemorrhagic or chylous effusion. Thank you for listening.
Thank you, Dr. Nurhan. Moving to our final case before we take a 5-minute intermission to a case from Ethiopia with Dr. Habtamu Segaye, talking to us about a hyperdense paracellular mass, atypical imaging features of intracranial dermoid cyst.
Hello, everyone. I'm Habtamu Segaye, radiology resident from Bahadar University, Ethiopia, and I'll be presenting a case on hyperdense paracellular mass presenting as atypical imaging feature of intracranial dermoid cyst. And my mentor is Dr. Adamu from radiology from Bahadar University, and I will be presenting to the case. This is a 27-year-old male epileptic patient who is on antiepileptic treatment for the past 2 years and currently present with complaint of blurring of vision and headache of 1 year duration, and ophthalmologic evaluation shows bilateral papilledema, and CT was requested to rule out intracranial spacer combined lesion. And on the CT scan, it shows a large, well-defined hyperdense mass on the right middle cranial fossa, which has significant mass plate with a midline shift of 10 mm to the left side. And on the coronal and sagittal image, it shows non-enhancing hypodense solid component, which is peripheral located, as indicated by the arrow, and it has also peripheral rim calcification. And on the bone window, there is no bone change or remodeling is seen in the adjacent basal skull. So taking the CT features, the top differential consider were extraction cystic mass with internal hemorrhage, and the other differential consider was meningioma, but no enhancing component is seen, which makes meningioma least likely. So for further characterization of the mass, MRI, brain MRI was requested, and on the brain MRI, the mass appears as T1 bright and T2 homogeneously T2 dark, and the hypodense solid component on the CT, it appears as T1 hypo and T2 hyperintense signal intensity, which is peripheral located as into the basal skull. And on the TASO, no also the post-contrast enhancement and no diffusion restriction is seen. It appears as signal void on both DW and ADC. So taking the CT and MRI features, an extraxial cystic mass with proteinaceous components was considered, with the top differential considered was dermoid cyst and atypical epidermoid cyst. And the patient was surgically managed. Total section of the mass was done, and the intraop finding was a large cystic mass having dark yellow thick content mixed with hair. And the post-op course was uneventful, and the patient was discharged 10 days after surgery. And biopsy was sent, and the histopathologic evaluation shows a fibrous cyst wall lined by keratinizing squamous epithelium, having skin adnexa and cyst containing hair and sebum, which in conjunction with the intraop finding confirm the diagnosis of dermoid cyst. So coming to the discussion, dermoid cysts, they are rare congenital inclusion cyst of the brain, which accounts for less than 1% of all intracranial tumors. Even if they are rare, they have typical CT and MRI features where they are midline in location, and they have typical non-enhancing fat attenuation on CT and appear as hyperintense on T1 with variable signal T2 with a T2 MRI. This is the typical feature of dermoid cyst, but in atypical case of dermoid cyst, which is extremely rare and pose a diagnostic challenge where they appear as hyperattenuating on CT. This is due to the high protein content. And in some, there are also some few case reports which has mural nodule with post-contrast enhancement. So this case, it poses a dilemma with which mimics other neoplastic cystic tumors with smaller nodules. And the differential diagnosis for this atypical imaging feature of dermocyst is atypical epidermocyst, where epidermocysts are also inclusion cysts, which are more common than the dermocyst, and typically they are located in the CPA and paramedian location. And on imaging, typically they have relative safe intensity and density on CT with characteristic diffusion restriction. Whereas in about less than 10% of cases of epidermocyst, they have atypical imaging feature where they will appear as hyperdensity on CT, and they will appear as T1 hyperintense with variable T2 signal intensity and diffusion restriction. But in few case report also shows hyperdense and hyperintense on T1 with variable signal on T2 with no diffusion restriction. So the take-home points from our case is that dermocysts are not always fat attenuating and they are not always midline location. So the recognition of this atypical feature can avoid a diagnostic pitfall and is clinically relevant for overall surgical management. So here is my reference. Thank you.
Thank you, Dr. Tsegaye. Very interesting images, informative. We were able to learn about atypical features of a paracellular mass. Thank you. Now, moving to a 5-minute break. Please scan this QR code to give us some feedback about the case competition, point out some things we need to improve, and so on. We leave you for some music now from Africa. I hope you enjoy, and we'll be back around 10:50. Okay. Welcome back, everyone. We're gonna proceed with the cases. I would like to remind you to stick around till the end of this competition to be able to vote for your favorite case. We're gonna have a poll for you to vote, and this depends on you to choose the People's Choice Award that will receive also a money prize. Moving to Malawi, a case by Dr. Olive Kiwinda about a chronic cough in a child with an unexpected etiology. Let's see what we have.
Hello, everyone. My name is Olive Mukunda, and I'm a first-year radiology resident from Malawi. I'll be taking you through a case presentation of a child who presented to our facility with chronic cough, which was found to be due to quite an unexpected etiology. Starting with the history, an 11-year-old female presented to our facility with a 7-year history of dry cough and shortness of breath. 4 days prior to presenting to our facility, she had started to drain pus from her chest wall, and this was thought to be due to an abscess, but incision and drainage attempts were unsuccessful. She came to us as a referral from Cholo District Hospital, which is a secondary healthcare facility 1 hour away from us. In this district, she had had multiple reviews and admissions at the district hospital and several smaller facilities within the district, but continued to deteriorate despite multiple treatments. This included a full course of TB treatment and different antibiotics. Prior to the illness, she had been well for the first 2 years of her life and had an unremarkable birth history. This illness had severely disrupted her education, and her parents had resorted to taking the child to traditional healers to seek answers for her unending pathology. On physical exam, the child was found to be mildly malnourished and had finger clubbing. On chest exam, she had reduced air entry on the left side with a dull percussion note in all zones of the left. She also had asymmetrical chest expansion and tracheal deviation to the right. Examination of other systems was unremarkable. She had a raised white cell count of 17.4 and microcytic anemia. Her HIV test was negative. As part of the initial investigations, a chest X-ray was requested. This is a chest X-ray of the 11-year-old female that was taken on the day of admission. It shows complete opacification of the left hemithorax with reduced interrib spaces. There was also this radiopaque abnormality in the midline, which at this point was suspected to be artifactual. The clinicians had a working diagnosis of empyema after looking at this X-ray, and a chest drain was inserted, but drained nothing. At this point, a chest ultrasound was requested. This is an ultrasound of the left side of the patient's chest with the ultrasound probe placed in a longitudinal position. It showed dilated airways with mucus within some of the airways. This was on a background of consolidated lung, which you can see between the ribs. This was unexpected because everybody expected to see a big empyema on the ultrasound. At this point, a CT scan of the chest was ordered. The CT scan surprisingly showed a foreign body in the left main bronchus, shown by this radio-opaque abnormality seen in the left main bronchus. Aside from this, it also showed a destroyed left lung with dilated bronchi and an air fluid level in some of the bronchi. The chest cavity was also deformed, as you can see the reduced interim spaces here. And there was also these lucencies in the subcutaneous tissue, which were due to the sinus that was draining past from the chest wall. With the working diagnosis of foreign body, the patient was taken to theater for a bronchoscopy. The foreign body was surprisingly found to be charcoal. At this point, a left thoracotomy and left pneumonectomy was also done to remove the destroyed lung. At clinic, follow-up a few weeks post-op, the child is doing well, is thriving, and is back in school. This case teaches us about some of the detrimental effects of a chronic foreign body aspiration and the severe complications that can be there, like destruction of the airways and formation of abscesses that we saw in this patient. Earlier detection of this pathology could have saved the patient a lot of wasted years and could have saved the family a lot of struggle in taking care of the patient, and she would have had a better education and better quality of life. Accurate interpretation of medical imaging leads to more effective treatment. We wondered what would have happened if an earlier chest ultrasound scan of the patient had been done. And this case prompts us to always think about alternate differential diagnosis when a patient doesn't respond to treatment in the way that we expected. Appropriate interpretation of medical imaging improves patient outcomes and reduces recovery time and improves the patient's quality of life. Thank you for listening. These were my references.
Thank you, Dr. Mkiwinda, highlighting the importance of radiology in the diagnosis of the previous case. Moving to Kenya with Dr. Taleni Shafashike, talking to us about a positional change in the retropharyngeal carotid artery.
Good afternoon, everyone. My name is Taleni Shafashike, and I am a third-year radiology resident at the University of Nairobi. The title of my presentation today is Positional Change in the Retropharyngeal Carotid Artery, an African Case Report. My mentors are Dr. Kellen Onyambu and Dr. Mathenge from the University of Nairobi. I do not have any disclosures to make. The patient I'm presenting today is an elderly Kenyan woman who was 74 when she presented with an enlarging fungating right-sided scalp mass of several months duration. She had no comorbidities and no significant medical or surgical history. On physical examination, she was in a fair general condition, and apart from the presence of the large fungating right-sided scalp mass, the exam was unremarkable. A biopsy of the mass was done, and the histology came back as a malignant proliferative pilar tumor. She subsequently underwent 2 CT scans for staging. The first CT scan was a contrast-enhanced study of the head, which demonstrated the presence of a large, heterogeneous, non-enhancing, ulcerated, soft tissue mass with calcifications arising from the right frontotemporal parietal region with infiltration of the galeal aponeurosis. There were no features of osseous involvement or intracranial extension. An incidental finding of a retropharyngeal left common carotid artery was made, as demonstrated in this axial MIP image at the level of the hypopharynx. The left common carotid artery is seen medially deviated and located directly behind the left piriform sinus, with a distance from the artery to the medial pharyngeal wall of just 1.8 millimeters. This is a coronary format, again MIP, demonstrating the medialization of the left common carotid artery with mass effect on the hypopharynx. And the artery is also seen to wrap around the internal jugular vein prior to its bifurcation into its internal and external branches. 1 month later, the patient underwent a CT scan of the neck, the chest, the abdomen, and the pelvis to assess for metastatic disease. No evidence of mets were found, although she was found to have some suspicious cervical lymph nodes. On re-evaluation of the carotids, it was found that the left common carotid artery had returned to a normal lateral position, as demonstrated in this axial MIP image, again at the level of the hypopharynx. Course of the disease. The patient was discussed at the weekly head and neck tumor board meeting, where she was classified as having resectable disease. The proposed treatment plan was wide resection of the mass, skin graft and neck dissection, and then possible adjuvant chemoradiotherapy based on the nodal histology. However, the patient declined the surgery and did not receive any treatment. As of January 2025, which is 4 months since the MDT meeting, her family reports that she remains in a fair general condition, although she has developed new lesions on her scalp. Discussion. The retropharyngeal carotid artery is an uncommon anatomical variant which has been known about for more than 100 years, with a rather wide estimated prevalence rate. Recognition of this variant is of enormous clinical importance to avoid injuries during procedures such as tonsillectomy or endotracheal intubation. In 2012, the first case report of migration of the carotid artery from a retropharyngeal to a normal position over time was documented. And since then, there have been 9 more such cases reported in the English literature, including 1 case report in which the migration occurred during the course of a single MRI examination. To our knowledge, the case being presented here today is the first case report from Africa. The risk factors and associations of this migration have not yet been fully elucidated due to the small number of cases to date. Take-home points are that the cervical vascular anatomy is not as static as previously thought, and as radiologists, we should assess the position of vital vasculature in every scan that we report, and head and neck surgeons should be aware that they should always confirm the location of the carotid artery during procedures and not rely solely on radiological investigations. Thank you. These have been my references.
We know that.
Very interesting case. Thank you for sharing with us, Dr. Shafashike. Now, moving back to Ethiopia with Dr. Abdul Majid Suleiman, presenting an ileocolic and appendiceal intussusceptions with acute appendicitis, a chicken and egg scenario.
Hello, esteemed audience. My name is Dr. Abdul Majid Suleiman. I am a third-year radiology resident from Addis Ababa University, Ethiopia. I want to thank Penn Radiology for giving me this opportunity. The case I want to share with you is a case of ileocolic and appendiceal intussusception with acute appendicitis, a chicken and the egg scenario. My collaborators are Lul, pediatric radiology fellow. My mentor is Professor Daniel, consultant pediatric radiologist. Here is my outline, patient presentation, imaging, management, discussion, and take-home points. I have no disclosure. Patient presentation is a 7-year-old male patient who presented with colic abdominal pain and vomiting of severe duration. On examination, he had right lower quadrant abdominal tenderness. On laboratory, he had normal white cell count with left hip. On imaging, on ultrasound, on the transverse scan of right upper quadrant, which is thickened ball with internal areas of additional collapsed ball loops. Also, this oval hypovic structures with central colic areas, likely iliac lymph node. So this is typical for ileocolic intussusceptions. Given the patient age is older for ileocolic intussusception, is 7 years old, we looked for possible lead point. And when we scanned lower in the right lower quadrant, we saw this again, ball within a ball configuration. This time we have this terminal ileal loop, we have mesenteric fat, and we have, this is a cecum. We have also this endotubular structure, which is blind ending with posterior acoustic enhancement and with a diameter of 1 centimeter. So with this, we establish a diagnosis of ileocolic interception with acute appendicitis. This is a cine clip. You can see this ball within a ball appearance, giving us the target sign. In the lower down, you can also see tubular blind ending structure posterior to the terminal ileum, also going into the cecal loop, into the cecum. In this region, especially, you can see both the appendix as well as the cecum, the ileum, the terminal ileum going to the appendix. So for this patient, surgical team was around, and we initially thought this should be operated, but they said it could be a Matus appendix, and we tried hydrostatic reduction, which was initially successful. Post reduction, there was distended appendix. Again, the surgical team thought that this is just a swollen appendix because of being dragged into the cecum along with the ileum. Next day, patient came back with sonographic and clinical symptom recurrence. With similar findings with ileocolic dissection and also thickened and distended appendix, which is non-compressible. Then surgery was decided intra we have this the cecum, the terminal ileum. This is the appendix. The appendix invaginating with the base of the cecum, giving us this additional diagnosis of appendiceal interception. There was also a component of ileocolic interception, which was reduced, and the appendiceal interception was reduced, and we can see this appendix is hyperemic and distended, and they did appendectomy, and we can also see this hyperemic terminal ileum. This is the cecum. So for this patient, finally a diagnosis of ileocolic dissection, ileocolic and appendiceal dissection with acute appendicitis was established. So this appendiceal dissection is a very rare scenario. It accounts for 0.01% of all appendectomies. And it is invagination of appendix into the cecum or sometimes into itself, usually caused by anatomic factors like hypermobile mesoappendix, fecolid, and other times because of hyperplasia. Sometimes even acute appendicitis can induce these appendiceal disceptions. So usually whenever we have ileocolic dissection appendicitis, especially on imaging, we have to consider a possibility of secondary appendicitis. Whenever there is ileocolic interception, the appendix will be dragged along with the ileum into the cecum, and it will become obstructed, distended, and superinfected with secondary types of appendicitis. So the appendicitis and the ileocolic interceptions are usually egg and the chicken phenomenon. Difficult to know which comes first, but the important thing is to identify that there is a component of acute appendicitis along with ileocolic interceptions, because it has a management implication. Such a patient usually does not improve with hydrostatic reduction. They will have recurrent ileocolic interceptions unless it's surgically manually reduced with appendectomy. So unless we do this, patient can come back with perforated appendix, increasing the mortality of the patients. The take-home point is from this case, you have to avoid satisfaction of search error, even in the common cases like appendicitis and interception. And we have to look for lead point for all. In older children, we have to early identify acute appendicitis occurring with ileocolic interceptions, because this allows appropriate management and prevent the complication. The reason I choose this case is it teaches us uncommon presentation of common cases, and it is a good teaching case even for a beginner as well as for senior residents. Thank you for listening to me.
Thank you, Dr. Abdul Majid, for this interesting case. It is really a case of a chicken and egg scenario. Moving to Nigeria now with Dr. Anikeme Bassey, presenting a uterine leiomyosarcoma, a case of rapid tumor progression in a young patient.
My name is Dr. Anikeme Bassey. I'm a third-year radiology resident Babcock University Teaching Hospital, Nigeria. I'll be presenting uterine leiomyosarcoma, a case of rapid tumor progression in a young patient. This is a case of a 36-year-old nulliparous woman with history of abdominal pain and swelling of 2 weeks duration. The pain was gradual in onset, dull in character, and she rated it 5 on the severity scale of 10. Pain was also relieved by analgesics. She noticed an abdominal swelling which started in the lower abdomen, initially the size of half a fist, which later progressed to become the size of a full fist within a space of 2 weeks. No history of abnormal vaginal bleeding, no urinary symptoms or gastrointestinal symptoms. She has a gynecological history of 2 first trimester miscarriages and also a prior ultrasound diagnosis of uterine leiomyoma. No history of smoking or significant alcohol intake. On examination, a thin, tender, non-mobile pelvic mass of about 16-week uterine size was palpated. Pelvic ultrasound scan was done, which revealed a large heterogeneous uterine mass with marked vascularity on color Doppler interrogation. Pregnancy test done was negative. Pelvic magnetic resonance imaging was carried out, and the imaging findings are as follows. This is a T1 weighted axial image of the pelvis showing an enlarged uterus with lobulated outline. It contains an ill-defined hypointense mass, which is predominantly in the right lateral myometrial uterine wall. There's also T1 hyperintense collection within the endometrial cavity. On T2 sagittal image, the mass is T2 hyperintense and is seen to extend up to the level of L4 vertebra. There is compression of the posterior wall of the urinary bladder by the enlarged uterus, causing segmental loss of fat plane between the posterior wall of the urinary bladder and anterior wall of the uterus, giving a suggestion of local invasion. Mixed intensity but predominantly T2 hyperintense recollection is seen within the endometrial cavity, and also fluid is seen to surround the mass as well as the pouch of Douglas. Post-ganglionium contrast image shows homogeneous contrast enhancement of the mass, and also there was restricted diffusion as evidenced by DWI hyperintensity and corresponding ADC hypointensity. Based on the pelvic MRI findings, diagnosis of uterine leiomyosarcoma was suggested, and endometrial carcinoma as well as carcinosarcoma of the uterus was given as possible differentials. Exploratory laparotomy was carried out, and tumor imprint cytology showed malignant cells. Histology eventually confirmed leiomyosarcoma, and the treatment that was carried out was total abdominal hysterectomy with bilateral salpingo-oophorectomy. Post-operative chemotherapy was initiated, which patient is still currently undergoing. Discussion and take-home points. Uterine leiomyosarcoma is a rare but aggressive uterine malignancy, often present with rapid tumor growth, which may also mimic uterine fibroids. Although a way of differentiating uterine fibroid from uterine leiomyosarcoma, pelvic MRI findings is very instrumental, as restricted diffusion will be seen in uterine leiomyosarcoma, and there is more uptake of contrast in uterine leiomyosarcoma compared to fibroids. There is a high recurrence rate of the mass even after treatments. Although peak incidence is in the 6th decade of life, the index case occurred in a younger patient, so all bets are not off in young patients. Primary treatment is surgery. Chemotherapy may be beneficial for those who have very aggressive tumors or metastasis. Early diagnosis remains key for better prognosis. These are my references. Thank you for listening.
Oh, thank you for this interesting case. I'm moving back to Ethiopia with Dr. Jonas Ayaleu, presenting about myeloid sarcoma, presenting with unilateral orbital swelling and proptosis.
Hello everyone, my name is Dr. Nasrullah Tayale, SRD radiology student from Addis Ababa University, Kwambasa Specialized Hospital. Today I will present you a case of myeloid sarcoma, presenting with unilateral orbital swelling and proptosis in the absence of systemic hematologic disease. I would like to thank my collaborator, Dr. Uladane, and my mentors, Professor Daniel Zauduna and Dr. Gash Araga, for their guidance and also expertise in the preparation of this case presentation. So just jump into the case. So here is a 7-year-old male child, last healthy 5 months back, presented with left eye upper eyelid swelling, pain, and discoloration of skin for about a period of 2 weeks duration, and otherwise he has no fever, night sweating, or significant weight loss. On physical examination, the pattern finding was left eye periorbital swelling and proptosis with associated ptosis and darkening of the left upper eyelid. Otherwise, there was no any palpable large lymphadenopathies, and there was no palpable organomegaly in the abdominal examination. The routine laboratory test was done, and the pattern finding was mild thrombocytopenia with platelet count of 136,000 per microliter. Otherwise, the other CBC parameters were within the normal range. So this child went on having MRI, and I brought here stative MRI images. So the first one is T2 axial, coronal, and sagittal reconstruction images. So here we see expansile infiltrative left extraocular solid mass lesion involving the left upper orbital quadrant, and the mass mainly involves the extraconal, the conal space, and its orientation appears to be along the left superior rectus muscle, and it has caused anterior inferior displacement of the globe. Otherwise, there is no, we don't see any bony orbital wall destruction, and we don't see also intracranial extension of the mass lesion. On post-contrast image, here is T1 contrast. Here is post-contrast showing homogeneous post-contrast enhancement, and the lesion appears to conform with the shape of the orbit, and there was no obvious extension to the adjacent paranasal sinus. So with this unilateral extraocular expansile mass lesion showing homogeneous post-contrast enhancement, rhabdomyosarcoma was considered top on the list with differentials of lymphoma, and tissue biopsy was requested from the left upper eyelid. The result showed malignant round luceo tumor, with the top differential being rhabdomyosarcoma, and marrow biopsy, aspiration, and also peripheral morphology was subsequently done, and all were normal. So with the diagnosis of rhabdomyosarcoma, he was admitted to oncology ward, and chemotherapy was initiated. But within the first 2 weeks of chemotherapy initiation, immunohistochemistry was requested based on recommendation of the attending pediatric oncologist, and the results showed cells diffusely positive for CD45, CD43, and myeloid peroxidase, and negative for myogeny, which is suggestive of myeloid sarcoma. And then the management subsequently revised, and induction chemotherapy according to ML protocol was initiated. So myeloid sarcoma is a form of solid extramedullary mass lesion due to immature leukemic cell infiltration. Usually it occurs in the setting of ML, usually during the diagnosis or after treatment, but very rarely it can precede ML, and it can pose a significant diagnostic challenge. Imaging differentials include lymphoma, rhabdomyosarcoma, neuroblastoma, and inflammatory conditions like orbital tumor. And on microscopy, it usually shows malignant round luceo tumor. It's actually an umbrella term, and it can be missed more than 50% of the time. And this misdiagnosis can result in also mismanagement, resulting in inappropriate surgical intervention, and initiation of also local radiotherapy may occur. The appropriate treatment for this condition, for this primary myeloid sarcoma, is systemic chemotherapy initiation like ML, for which it usually shows good response, and this systemic chemotherapy initiation also prevents the occurrence of systemic hematologic malignancy. So the take-home point is that when children present with specific eye swelling, discoloration, and pain, rare possibility of acute leukemia presenting with very similar clinical presentation has to be suspected, and myelosarcoma also has to be considered imaging-wise both on unilateral and bilateral orbital masses. And the last and most important point is tissue biopsy has to be always correlated with immunohistochemistry for final diagnosis so that appropriately treatment initiation can be done, and usually patients could have a better prognosis. Thank you very much. This is my reference.
Thank you. Thank you for the case. All the cases are really interesting and very informative. It's making judging very tough for us. Moving now to Malawi with Dr. Rashid Godfrey Galawango, talking to us about a case of atypical resistant Talipes equinovarus.
Hello, my name is Rashid. I'm a radiology resident from Kamuzu University of Veterinary Sciences, Malawi. I'll be presenting a case of atypical resistant Talipes equinovarus. My case is of a 5-year-old girl who was referred to our hospital as a surgical consultation after presenting with a history of resistant bilateral feet since birth. The disease was progressive despite video manipulation, casting, and tender Achilles tenotomy. There was nothing else of note at birth. There is, however, reported delay presentation because the parents believed that their child had initially been bewitched. At presentation, as shown in Figure 1, there was bilaterally marked feet deformity. The child was small for age with otherwise mild developmental milestones. The spine was not extremely deformed and she did not have any skin lesions. Sensation was normal with diminished knee and ankle reflex. At this point, the reviewing surgeons requested spine X-ray. Figure 2 is an image showing a lateral lumbosacral X-ray of the child, which showed multi-level posterior vertebral scalloping as shown by the blue arrows, as well as spinal canal dilatation as shown by the blue stars. This raised suspicion for an expansor intraspinal canal abnormality, hence requiring further investigation. An MRI and CT were then done. Figure 3 show multiple multiplane post-contrasted CT images showing a central large retroperitoneal soft tissue heterogeneously enhancing mass as shown by the green arrows, which displaces adjacent viscera and encases abdominal aorta as shown by the red arrow. There is also significant soft tissue intracanalicular extension with marked vertebral body bone remodeling as shown by the black arrow. In the non-contrasted MRI images, similar to the findings of the mass in CT as shown by the green arrow, there is better visualization of the intracanal component, which is T1 iso to hypointense and T2 iso to hyperintense, and appears to be anteriorly displacing and encasing the spinal cord as shown by the yellow arrow and its allied exiting nerve roots as shown by the red arrow. At this point, a decision was made to take the patient intra-op and to obtain a core biopsy. Figure 5 is a micrograph of the core biopsy, which showed cells proliferation in a loose maxillary stroma admixed with ganglion cells of ganglionoma. This led to a final diagnosis of a ganglionoma. A decision was then made to take the child intra-op with a two-step approach, whereby initially a laparotomy would be done and remove the intra-abdominal component of the mass, and then a month later, after the child had recovered, a posterior approach would be done by the spine surgeons to remove the spinal component of the lesion. Figure 6 are images obtained from the second phase of the procedure, and the green drape points towards where the head of the patient was. Image A shows exposed spinous processes and ligaments, while image B shows post-laminectomy and posterior elements lifted off, exposing the epidural mass as shown by the black arrow. And finally, figure C shows epidural mass dissected off the dura as shown by the green arrow and exposing the underlying spinal cord as shown by the yellow arrow. Patient was then discharged after spending about a week in ICU and an extra week in the ward. The plan was to follow up patient in clinic, as well as for the patient to undergo significant physiotherapy and receive nutritional support. So going to our learning points and discussion, ganglionuloma is a very rare benign tumor originating mostly from the sympathetic nerves. Even more rare is the congenital form, which was seen in our patient, with only a few cases ever reported. The median age of diagnosis is usually at 7 years, and there is a slight female predominance. Treatment usually consists of complete surgical resection where possible. Comprehensive follow-up is very important because recurrence is very common, and it's important that such recurrences are detected early. Our unique learning points from this case are cultural beliefs and conflict with modern medicine. For example, in this case, the parents believed that the child had been bewitched, which might have led to the delay in the treatment as well as diagnosis of the condition. Also in Malawi, there are no national antenatal ultrasound screening programs, which leads to delayed diagnosis of most congenital anomalies, and leading to patients presenting either neonatally or in early childhood, and in some rare cases in late childhood, which impacts treatment as well. Finally, there is also need for us to verify the importance of multidisciplinary team approach, as was seen in this case, whereby multiple teams came together in order to diagnose and treat and properly manage this patient. This is what I had for you. This is where my references. Thank you so much. Have a lovely day.
Thank you for the interesting case. Very informative about ganglioneuroma from Malawi. Moving to another case from Nigeria, Dr. Amankem Okori, presenting about mediastinal foreign body following penetrating injury to the neck.
Hello, my name is Amankem Chidera Okori, and I'm a resident in the Department of Radiation Medicine, University of Nigeria Teaching Hospital, Enugu, Nigeria. I'm presenting mediastinal foreign body following penetrating injury to the neck. It all started when a 16-year-old boy fell into a ditch while riding a bike. He sustained penetrating injury to the left side of the neck and had bruises on his arms, feet, and torso. His wounds were cleaned and closed up at a primary healthcare center, and the patient was discharged home. However, 4 days later, he presented to the hospital following onset of neck pain, dyspnea, dizziness, and fever. At the emergency room, clinical examination suggested a pleural collection, and the patient was sent to radiology department for an emergency chest X-ray. The chest X-ray revealed a left-sided superior mediastinal widening with a convex lateral border, and there was also a partial obscuration of the aortic knuckle with blunting of the left costophrenic angle. There were no rib fractures. The left-sided superior mediastinal widening is shown by the red arrow in the image, and the blunting of the left costophrenic angle is shown by the yellow arrow. Following these, an impression of a left-sided hemothorax with possible aortic injury was made, and an urgent contrast-enhanced chest CT was requested. The chest CT showed a left-sided superior mediastinal hypodense thick-walled cavity. And this cavity, the wall was regular and showed marked contrast uptake, and this is shown by the red arrow in the image. The central portion of this cavity harbored a rectangular area of air density, and within this rectangular area of air density, there was a linear structure of soft tissue density, which is likely an organic matter, and is shown by the yellow arrow. The cavity communicated with the injury at the base of the neck through this tract of locus of air density that goes through the soft tissues, and these are shown by the blue arrows. The aortic arc was found inferomedial to this collection, and it is intact. All the surrounding vessels, the adjacent vessels to this collection, were intact, and there was no extravasation of contrast from any of these vessels seen. And this is an axial slice of the same CT image showing the collection, which is shown by the red arrow. And this right here is the arc of the aorta, which is close to this collection, and at the same time, it's unharmed. There's no extravasation of contrast seen. This CT is to show the relationship between this collection and the left pulmonary, the upper lobe branch of the left pulmonary artery, which is labeled with the orange arrow. It can be seen inferior to this collection, and it is also unharmed. This is an axial CT image at the level of the carina, showing the ascending aorta labeled A, the descending aorta labeled B, and the collection. You can see how proximal this descending aorta is to this collection, also unharmed. A diagnosis of a mediastinal abscess secondary to an organic foreign body, which was likely wound, was made, and this patient was booked for surgical exploration. However, a day to the booked surgical exploration, there was a spontaneous rupture of the previously healed neck injury with a marked efflux of purulent material and reduction in body temperature, and the patient was sent back to our department for a follow-up chest X-ray. And this chest X-ray showed a reduction in both the size and the density of this superior mediastinal widening. And it also showed a resolution of the blunting of the left costophrenic sulcus. And if you look at this image, you will find that there's a reduction in both the size and the density of this superior mediastinal widening. Following this, the surgeons decided to put a halt on the surgery and place the patient on parenteral antibiotics, ceftriaxone and metronidazole, and the patient was scheduled for follow-up chest X-rays and CT images to be monitored. Now, in keeping with this competition's theme of non-communicable diseases, we present this case to highlight trauma as an important etiology of this class of conditions in the developing world. Prompt diagnosis of involved organs, degree of involvement, and associated complications will help minimize morbidity and mortality. Thank you.
Thank you, Dr. Okori. Moving to Kenya again. This case is going to be colorectal adenocarcinoma in a 12-year-old from Dr. Koki Mutungi.
My name is Dr. Koki Mutungi. I am a radiology resident in Aga Khan University Hospital, Nairobi, Kenya, and my supervisor for this project was Dr. Benedict Muthe, a pediatric radiologist. I'll be presenting a case of colorectal adenocarcinoma in a 12-year-old. The patient presented to our facility with a 3-month history of rectal pain, on and off hematochezia, and failure to gain weight. He had presented to 2 other facilities prior with similar symptoms and had been managed for amoebiasis with no resolution of symptoms. His physical exam was unremarkable. On DRE, there was no palpable mass, no fissure, and no blood on the examining finger. As part of his workup, the total blood count and CRP were normal. However, his occult blood stool test was positive. He was scheduled for a colonoscopy and abdominopelvic MRI. The colonoscopy showed a near circumferential lesion in the rectum, extending 5 centimeters with ulceration and bleeding. Histology of the biopsy sample taken was reported as moderately differentiated adenocarcinoma with a signet ring component. I'll be depicting the most relevant sequences and planes of the most pertinent findings on MR. In this sagittal T2-weighted image of the rectum, you can see circumferential mural thickening, which is hyperintense on T2. In this axial DWI image of the rectum, we can see circumferential mural thickening, which demonstrates high signal on DWI. On ADC, there's corresponding low signal in keeping with restricted diffusion. We can also see this hyperintense lymph node, mesorectal lymph node on DWI. Axial post-contrast image of the rectum showed again circumferential and irregular mural thickening with heterogeneous enhancement. He did go on to do a completion CT chest, and based off of the cumulative findings, his TNM staging was T3A, which meant that the tumor invaded the mesorectum and mesorectal fascia However, the depth was less than 1 millimeter. N2, because he had 4 to 6 regional lymph nodes in the mesorectal, obturator, and internal iliac stations, and M0, because there was no evidence of metastasis to the liver, other abdominal organs, or to the chest. Circumferential resection margin, which is an important factor for surgeons to consider, was positive between 3 and 6 o'clock position. There was no sphincter involvement. He went on to undergo ultra-low mesorectal excision with coloanal anastomosis and a formation of a temporary loop distal ileostomy to allow the anastomotic site to heal. He was scheduled to undergo 12 cycles of chemotherapy with a FOLFOX regimen, as well as capecitabine and adjuvant radiotherapy. He has currently undergone 7 cycles of chemotherapy and 1 cycle of radiotherapy. I brought this case up to discuss colorectal cancer, which in the pediatric age group is rare, accounting for 1% of malignancies. And in terms of GI malignancies, it is second to lymphomas. Most cases are sporadic. However, some risk factors that have been identified are IBD, including ulcerative colitis and Crohn's disease, as well as polyposis syndromes. In children, it is more difficult to diagnose it given how common and nonspecific the GI symptoms are. Therefore, in the pediatric patient whose symptoms are not resolving despite management, colonoscopy should be considered, and if indicated, cross-sectional imaging with CT or MRI. It's also important to diagnose this early because late diagnosis contributes to the low or the poorer prognosis. In addition, children tend to have the mucinous adenocarcinoma subtype, which in and of itself is a poor prognostic factor. Thank you for your time. And these are my references.
Thank you, Dr. Mutungi, for that interesting presentation. Moving to our final case from Egypt, Dr. May Saeed talking about advanced abdominal ectopic pregnancy. Thanks to everyone who submitted. After this case, we will have a brief intermission for the judges to score all the cases, and we pick the top 3 winners, and the poll to vote for the People's Choice Award will also be available. So stick around, and I hope you enjoy this last case from Egypt.
Hello everyone, my name is May Sami Abab Saeed. I am resident year 1 Radiology Department at Shams University Hospital, Egypt. Today I'm presenting advanced abdominal ectopic pregnancy, a case report. My mentor is Dr. Amal Ibrahim Ahmed Osman, MD Radiologist, and other team member is Dr. Shima Abdulsattar Mohammed, an MD Radiologist. So, starting with the history of our patient, she is a 26 years old primary gravity patient at the 33-week gestational age, complaining of the antepartum hemorrhage for 10 days of the regressive course. The past medical history was irregular cycle and polycystic ovarian disease 2 years ago, with improvement after treatment. Then she showed regular cycle for 1 year, still her pregnancy. Patient noticed her pregnancy by absent cycle for 2 months and confirmed by the pregnancy test. On examination, the patient was hemodynamically stable with a normal vital sign, and after doing an abdominal ultrasound, ectopic pregnancy was suspected and MRI was requested. So MRI findings show there is a single intra-abdominal extrauterine pregnancy. The fetus was pre-presentation at the time of the examination. Placental tissue is in the right side of the pelvis, showing the feeding vessels from the right internal iliac artery, from the right uterine artery, and branches from the right inferior epigastric artery. The right ureter, the mid-segment, was compressed by the placental tissue with a subsequent proximal hydroureter and hydronephrosis. The placental tissue is seen away from the urinary bladder. It displays the bowel lobes with the no infiltrations. So this is an sagittal T2 weighted imaging showing an extrauterine gestational sac containing the fetus, and this is a graph of empty uterus is compressed down by the gestational sac. And this is a coronal T2 weighted imaging showing an extrauterine gestational sac in the left side. The baby is a breech in the presentation. This is the placenta at the right side as the pelvis, and the uterus is empty and brevet and deviated to the right side, and this is a urinary bladder. It's deviated to the left side with no infiltration by the placental tissue or the gestational sac of the fetus. This is an axial T2 weighted imaging showing the right pelvis placental tissue. This is the placental tissue with a feeding artery from the internal iliac artery with a signal void of the artery, and these branches are arising from the inferior epigastric artery and also feeding artery for the placenta. This is a gestational sac and containing the fetus in the left side. This is an axial T2 weighted imaging showing a compression of the right ureter, the mid segment, by the placental tissue. This is a placental tissue. Again, this is a gestational sac and containing the fetus. So treatment, the pregnancy was immediately terminated surgically by the laparotomy, and after that, the baby stayed in the neonatal ICU for 15 days. Mother received chemotherapy for the residual placental tissue, which is infiltrated and hard to be resected. The mother and the baby were well and were discharged. So take-home message that abdominal ectopic pregnancy defined as ectopic pregnancy occurring within the peritoneal cavity outside the genital organ, representing a very rare form of the ectopic pregnancy. Its only form of ectopic pregnancy can result in the delivery of the healthy full-term baby and with very high maternal and fetal morbidity and mortality. It's obstetric emergency, the role of the radiologist before termination to guide radiologically the position of the fetus, the placenta, if there is any infiltration or complication, and a high index of the suspicion and the true clinical ultrasound examination are crucial to diagnosis of abdominal pregnancy. And ultrasound, especially the transvaginal, remain the first line tool for diagnosis of abdominal pregnancy, and standardization of the treatment principle for advanced abdominal pregnancy, pre-operative treatment option, and a post-operative management measure will improve the newborn survival, reduce the complication and the mortality. These are the reference for our cases, and thank you for you.
Thank you everyone who submitted and everyone who's attending. We have around 140 viewers currently, and this is the time for judging and the time for you to provide some comments as well through the feedbacks, the comment section. The judges are now scoring the cases to pick up the top 3, and as you can see here, you have the polls to vote for your favorite case. We'll meet in 5 minutes. 10 minutes. Stick around, please.
Why can the I know.
I'm here.
Okay, we are back. I hope you guys enjoyed the music. Courtesy of our in-house DJ. And so I been given the privilege of announcing our winners today. I'm going to start with the People's Choice. Is that fair? So the People's Choice,
Can you lean forward?
as voted by the people in attendance today, is Anike Mebasi, uterine leiomyosarcoma, a case of rapid tumor progression in a young patient from Nigeria. Well done, well done. Then, so to our top 3 right now. Third is mediastinal foreign body following penetrating injury to the neck by Aman Kem Okorie. Are you sure you spelled this right?
Yeah.
Okay. All right, so give it up for our third place winner. Second place, complete cerebellar agenesis in a living person, Joseph Abedu Wilson from Ghana. And first place is chronic cough in a child with an unexpected etiology by Olive McWinda.
Yeah.
First place winner, Olive McWinda, chronic cough in a child with an unexpected etiology from Malawi. Great job, great job. And there you have it. And so as you guys know, the People's Choice gets $250. Third place gets $250. Second gets $500, as well as a trip to from RSNA 2026, courtesy of our RSNA's sponsors, providing the travel grant. And then the first gets $1,000 as well as a travel grant from RSNA. So congratulations again. And remember, everyone is a winner today. You know, for those who did not end up in the top 3, remember we will be back doing this again at an unannounced time right now. But thank you for hanging out with us today. Is there a survey that you want to?
Yeah.
Okay.
Yeah, just say.
There will be a survey shared with you guys to provide some feedback to us to continue improving our product. So thank you very much.